Shalom. Hi, hola. Good morning. Welcome to this second day of this very exciting workshop between Tel Aviv University scientists and Campus Clinic. So today we will have a first scientific sessions with 2 talks. Then we'll have a coffee break. And then we will have a discussion about potential collaborations. And we will close around 12 with official remarks and conclusions. I welcome also the people online, and actually this is a message for you. If you are in the building here in SEC, you can come downstairs, there are lots of seats, and there will be coffee break available afterwards. Okay, so let's start with the scientific talks. First, today the session will focus on neuroscience. The first talk is from Dr. Leo Mayo. He leads the group on autoimmunity and neuroimmunology at Tel Aviv University, trying to understand the mechanisms of autoimmunity and inflammations that underlie several neurological diseases, using multiple approaches and basic and translational approaches. He's also director of the Research Hub in Immunity and Inflammation and co-director of the Single Cell Genomics Core. Thank you, and I leave you the floor.
Okay, so thank you all brave people who actually showed up. So I'm going to talk today about a bit about neuroimmunology and what's going on. I will give you a taste of different projects we have just as an oversight. So when we think about targeting neurological diseases, we're basically thinking about how we can affect the immune response in the CNS, central nervous system. So when we think about the immune response in the CNS, we have to consider 2 different components. So we have to think about we have to think about the cells within the central nervous system, the glial cells. And when we talk about that, we talk about mainly, in that respect, the astrocytes and the microglia cells, which is kind of the local macrophages. And we have to consider the peripheral immune system that comes into the brain. And we talk about T cells, B cells, monocytes are a major player, and we're going to discuss them today. And also additional cells, and it's just keep multiplying. And the interaction and the communication and the crosstalk between the 2 is actually what is mediating the neuroinflammatory or the neuroimmunology disease. So I'm going to focus today about astrocytes, so just to give you a bit of an oversight about astrocytes. So basically we know about them for the past 200 to 250 years. In the beginning, they were thought to be some kind of a scaffold, basically holding everything in place. They're the major glial cells in the brain. Somewhere around the late 80s, we're starting to understand they have a role in the formation of the blood-brain barrier, in homeostasis, in metabolic control. There are some talks about the ability to affect neuron activity by the triple synapse. And somewhere around the beginning of the 2000, 2005 and on, we are understanding that they do have an immune function. And slowly more papers are coming up talking about their immune function within inflammation. And in the past 5-10 years, it's becoming we're kind of going back and also understanding that the metabolic function of those astrocytes play a major role in mediating the inflammatory response within the CNS, and I will give you a few examples today. And if I have to discuss, which cells can astrocytes talk in terms of the immune system, then basically everyone. They can affect T cells, they can affect B cells, they can induce activation, they can halt their activation, they can polarize them differently, they can kill the cells. They do affect multiple functions within that communication. So understanding the immune response is one thing, and then identifying targets that we can affect and regulate is a major different question. And that kind of brings us to something that I'm very interested in, and that's immunometabolism. And what is immunometabolism? Immunometabolism is basically the connection between the metabolic state of a cell and its ability to mount the activity or to mount the inflammatory response he wants to do. And when I'm talking about that, I want you to keep in mind that it's not like a car. When you talk about you have gas, you can go, you don't have gas, you can't go. It's the type of gas you're going to use will determine if you're driving forward, backward, right, or left. It can affect the cell's ability to mount a different response, the different bioenergetic that it will use and the different lipids that it will synthesize. It's that potent. And I put a BAB there because you always have to remember that the brain has its own metabolic environment. The blood-brain barrier will prevent many factors, metabolic factors within your blood, to come into the brain. For example, cholesterol. Cholesterol is widely expressed in the body. It's never in shortage. But cholesterol cannot cross the BAB, and it has to be resynthesized within the brain by the astrocytes. And there are many different metabolic factors that behave like that. So when we talk about the different metabolic aspects that can affect immunometabolism, so one, we talk about bioactive lipids or bioactive glycolipids, and we've been shown throughout the years that they do have a very major role. For example, the ability of astrocytes to produce a glycolipid called LACSER, lactosylceramide, is able to affect progressive MS, which is currently without any ability to any remedies available to it. We are going to talk a bit about cholesterol, and this is something I'm going to present today. This is a paper we actually resubmitted last week, and I'm waiting to hear from them every day. We need to talk about Krebs Cycle, which is NAD dependent and the ability to generate energy, and this is a paper that I'm not going to talk today, but we are submitting next week with a collaborator in Stanford. And we also have to talk about the mitochondrial hub as a place when things actually happen. It's not only the ability to produce energy. There are so many other things going on there, and actually in Charles' paper, that we basically were able to show that part of the lipid that affects this neuroinflammatory signaling is mediated through the mitochondria, which is pretty cool. Okay, so talking about that, and then the last challenge is actually how do you target the brain? We mentioned the blood-brain barrier, so blood-brain barrier is a problem. It prevents many drugs, many factors from coming into the brain. So we have to also find a way to kind of overcome that. Okay, and in my lab, what I'm interested in doing is understanding the immune response within the CNS. So we actually use two different types of models. In one of them, we'd use an overactivation of the immune system that attacks the brain, such as autoimmunity, and you can see that in multiple sclerosis. On the other hand, I like to look at GBM, a system when you have immunosuppression within the brain. So there's no response of the immune system toward the tumor, at least not the response they should have. And we are also double a bit with Parkinson and Alzheimer's because that's an interesting mix on that spectrum that we can see many things happening there. So just, a brief introduction about GBM. Dino talked about it last day, so I don't really have to go into it. But GBM is really a very devastating disease, and nothing really has been changing for the past 40, 50 years in the ability to treat those patients. So we wondered, can we actually understand what astrocytes do in GBM pathology, and can we modulate that? So astrocytes have a very interesting behavior in the tumor. They actually surround the tumor. You can really see the staining of the reactive astrocytes surrounding the tumor. And what we wanted to do is to understand, can we actually target and affect that? So the easiest thing to do if you want to see if something is important, just take it out of the system. So we have a model that we can actually kill reactive astrocytes. So this is the expression of HSV-TK under the promoter of GFAP, which is a promoter for reactive astrocytes. And in this system, when we administer the mice with ganciclovir, we can kill only the reactive astrocytes. So we're not killing all the astrocytes. We're only killing a subpopulation surrounding the tumor. And you can really see that in the staining. So everything is fine until you go to synthetic mice and you give them ganciclovir, and then you see that in the tumor margins, you have the disappearance of the blue staining, which is basically our reactive astrocytes. So we wonder what will happen if we implant a tumor, let it get established, and then kill the astrocytes. And when we do that, the results are quite dramatic. So if I look at the top image, and this is an IVIS imaging of the tumor, you see that in the wild-type mouse, the tumor is growing very dramatically, but when we start administration of the GCV after the establishment of the tumor completely disappeared. Actually, they disappear so much that if you look at the survival curves, about 80 to 70% of the mice will have a full remission. And this is when we actually stop the treatment with the GCV once all the wild-type mice die. So we are really able to completely eliminate the tumor, and we have done that in one cell line. And we demonstrated out in a different cell line and also in a different model of astrocyte depletion. So this is a really strong effect. So we really wanted to know what is happening there. Why do the astrocytes do? And I mean, how do they mediate that? So we tried to profile the astrocytes to understand exactly what they're doing. And first of all, it was very dramatic. The changes within the reactive astrocytes were immense. There were like about 4,000 genes that were upregulated or downregulated with a crazy p-value. It was super dramatic. And really, there were different functions that were going up. Different functions that were going up. I would just highlight several, like the CCL2, CD007, which is PDL1, and CSF1, which is super interesting. And what was also nice that when we took the signature of our reactive astrocyte in the mouse model and compared that to single cell analysis that was published before, we really see a very close similarity in the astrocyte cluster, in the same gene expression. So it's really mimicking not too bad the response of astrocyte in the human tumors. So, so many genes, we have to make some sense into it, and we try to profile them. And what you can see in this Manhattan plot is different pathways that we inactivated, and what we can see that we can cluster them into four main groups. One is immune regulation, the other one is metabolism, and the third is proliferation. So proliferation is really something that goes really well with our model of depletion because it's really depleting the reactive dividing astrocytes. That makes a lot of sense. But the metabolism and the immune regulation were really, really interesting. And when you talk about immune regulation in GBM, which I kind of consider as cold tumors, the first thing you think about are the tumor-associated macrophages. They really represent about 40% of the tumor mass in GBM. And so we wondered, can we affect the migration of those cells to the tumor? So we kind of look at the chemical profile produced by the astrocytes. We looked at the mouse cells and on the human cells. And in both cases, CCL2 was showing up as a major, major factor. And we kind of showed in vitro that we can really, the migration is really dependent on CCL2. And indeed, when we deplete reactive astrocytes, we see a marked decrease in the recruitment of tumor-associated macrophages into the tumor mass. And indeed, the CCL2 pathway, signaling pathway in human GBM has been shown to be really nicely correlated with the survival of those patients. And of course, the human astrocytes also express CCL2 in a very high level, so it's really all well connected. So we say, okay, we have less macrophages coming in, less TOMs coming in, but what do they do once they come in? So we kind of profiled, we kind of sorted the cells and we profiled them, and again, major, major differences in their ability to function, and trying to get some mechanistic into it, and I will not go into all the details because I don't have the time. What we're seeing is basically divided into 2 or 3 major groups. One is immune regulation, and we see that PDL1 is dramatically changing in those cells as other immune function related to the ability of TOMs to attack the tumor. Basically, we are kind of reverting the TOM to their original function to attack the tumor. It's really dependent on astrocytes, and it's also dependent on cytotoxicity. And what we can show is that microglia cells will kill GBM cells, but once you introduce astrocytes to the system, that will stop. And that this is actually dependent on the microglial ability to induce nitric oxide, which is really, really interesting. And we also were able to demonstrate that this mechanism is mediated through the secretion of CSF1 by the astrocytes. So basically, we can tell a story that says that the astrocytes are able to recruit the microglia and monocytes to the tumor that can affect with different factors, including CSF1, their ability to function and become and skew them back into being anti-tumor in their activity. But I also mentioned that there is a change in metabolism, which we find really interesting. So we collaborated with Eitan Rupin on the NIH to try to understand what exactly do they do. So Eitan has a really nice system in which he can take transcriptomic data and try to understand what are the perturbations to the metabolic pathways. And one of the things that was showing up was cholesterol. This is an image of a lipoprotein, which is basically how cholesterol is being driven between one cell to the other. And we know that astrocytes do produce cholesterol in the brain. Usually they do it to supply energy to neurons. And there is also reported GBM cells can hijack the system and use cholesterol from the cells. And what we were able to show, and I'll really go briefly through that, is that through a very simple system, when we grow different GBM cells in media that contains cholesterol or does not contain cholesterol, we see that once we grow GBM cells in a media without cholesterol, the cells undergo different bioenergetic perturbation, really attenuated their oxidability, and the survival really goes dramatically down. So in this, for example, you can see that without, the LPDS is basically media without cholesterol. We see that cell that is going dramatically up. Astrocytes are not affected because of that, because they produce their own cholesterol. And if you do a rescue experiment, growing the GBM cells in LPDS and then supplying cholesterol from the outside, we can actually revert this process and rescue the cells from the cholesterol deprivation cell death. And if you look at the interaction between the GBM cells and astrocytes, what is really clear to see is that without LPDS in a monoculture, the GBM cells will die really fast. But once we introduce astrocytes to the system in cholesterol deprivation, we stop this cell death, and we show that both in mouse cells and in mouse cells with primary astrocytes and in GBM cells with human GBM cells. Sorry, with human astrocytes, primary astrocytes. So how exactly is that being mediated, and can we affect it? So there's two different receptors that basically allow the astrocytes to release cholesterol to the media. It's ABCA1 and ABCG1, and indeed we can see that in the human astrocytes and also in the mouse astrocytes express only ABCA1. So we wondered what would happen if you modulate ABCA1 expression, and we had a very simple hypothesis. If indeed ABCA1 is the one that releases the lipoprotein-rich cholesterol and feeds the GBM, if you will take it out of the system, the GBM cells should die. So we generated a few viruses and infected the system, the co-culture system, when we downregulate ABCA1 within the astrocyte, and you can see that in the Western blots, and we actually got the effect we wanted in vitro. We got the cells to the GBM cells to start to die, but we really wanted to do that in vivo, because that's the main goal. And so what we do, we implant the tumor, then we inject lentiviruses that specifically target only the reactive astrocyte. They will not target any other cells. Trust me, we have done all the validations. And we can really see that the GFAP is the marker for the astrocytes, the GFAP is the marker for the reactive astrocyte, and you see that our viruses really surround the tumor pretty well in all the microenvironment, and it's really colocalized, trust me on that. And we asked the question, so what will happen? So first we validated that indeed we have a knockout of ABCA1 in the reactive astrocytes, and it's a very dramatic knockout. Then we validated that cholesterol contact in the GBM cells is going down. And indeed, this is a Philippine staining that shows cholesterol contact in the GBM cells. And you see that in the NT-control virus, we don't see, the levels are pretty normal, but once we deplete ABCA1 in astrocytes, you see the cholesterol levels within the cells go down. And I mentioned that we've shown in vitro that there's a strong connection between cholesterol and the viability of GBM cells. So the question was, will the GBM cells will die? And this is a Cas+3 staining of the tumor. And what you can see is a very dramatic cell death once we deplete the ABCA1 within the astrocytes. And indeed, if the cells die, should we see that also in other in the pathology of the disease? And the question is yes. We see in the IBIS plot that the tumors really go down. We see that in the survival of the mice. And of course, this is really well correlated to the survival data of GBM patients. So what we can say now is that we've shown that astrocytes affect the immune regulation of the system, specifically affecting the tumor-following macrophages. We also did some experiment with CD8, and the effect is not really well dependent on that. And we see a very strong interaction between the cholesterol and the survival and growth of the GBM cell, of the tumor cells. And I can tell you now that we are now investigating it further, and actually the cholesterol is also affecting the activity of the immune cells, which is pretty cool. So, but I promised you also some data about autoimmunity. So let's talk shortly about autoimmunity, and this is the model we basically like to use, the model of multiple sclerosis. Multiple sclerosis is an autoimmune disease in which the body attacks the myelin surrounding the axons, really destroying them and generating the effect we see in the disease. There are about 2.8 million people sick worldwide. The in terms of the mechanism of the disease, it usually begins when CD3 or CD or B cells come into the brain, attack the system, activate the glial cells, and then there's this vicious cycle. So today we are able to target both the B cells and the T cells, and we can have really nice effect. Not always, but we can manage the disease at least in the beginning of the disease when it's really dependent on the adaptive immune system. In later phases, we can't really do that anymore because it's not dependent on them. But the monocytes, which are really, really the foot soldiers of this attack on the myelin, we currently don't have any tool to attack. And one of the reasons we don't have any tool to attack them is because they are very, very similar to the phenotype of the microglial cells within the CNS, so we can't really distinguish them and able to target them. So we postulated that if you can find a specific marker for the monocytes, then maybe you can modulate disease progression. And not only can we modulate it, maybe you can really, really affect different aspects. For example, we can kill the cells before they come. So, and it's been shown before that in transgenic mice, if you will prevent the migration of monocytes to the CNS, you will completely block disease progression. But we can also use it to transfer payloads into the system. So since we can't really easily cross the BBB, we can take the drug we want, connect it to the monocytes, and they will carry it for us into the lesion area, and this is something monocytes do really, really well. And another aspect, we can use it also for diagnosis. I mean, usually when an MS patient comes to the doctor, he will tell him, go and do an MRI. The MRI will detect the lesion once it's formed. The MRI cannot detect any inflammation when it starts in early phases. Now, the problem is that we can stop inflammation today, but we cannot induce recovery. Okay? The ability of a MS patient to recover and to regain function, it's completely dependent upon its ability to regenerate the circuit, to regenerate myelin, to regenerate the oligodendrocytes, or to kind of circuit the neural network differently. But at some point that will stop working, and then there is nothing we can do. So we can actually use that to identify the entry of the monocytes to the brain before you have the damage. So think about an MS patient coming to the physician and doing a scan every couple of months. And once we see this flare, we can stop it before we have the damage. And last and not least, if we can also detect it in the CSF, that could be a very interesting thing to do also to detect it. So classically, when we look at the brain in effects, what we are seeing are in a naive CNS, we see the non-immune cells and we see the resident microglial cells. In an EAE, which is a model of MS, what we will also see is a population of the monocytes coming in and a population of the lymphocytes, CD3, CD4, CD8, B cells, and so on and so forth. And we actually identify the marker, and this is kind of a heat map display on it, and that is only found within the monocytes. And if you actually look at its co-localization with markers that we know are very efficient for monocytes, such as AY6C and CCR2, we see a really well co-localization between the two. And if you look at human patients, so if you look at the control, if you look at the healthy CNS, then basically we don't really see any expression in any brain or spinal cord tissue, but it's really elevated in the blood. And if you look at the lesions of MS, we really see this marker showing up in the lesions of MS patients. So indicating that it is interesting to study. And we have done fate mapping and bone marrow transplantation and histopathology and immunostaining and transcriptomic profile for the cells. And it's really, really evident that those are this is a very specific marker that is appearing on monocytes that come into the CNS. By the way, not only in MS, we can also see that in models of Parkinson and in models of GBM, and et cetera, et cetera, et cetera. It's a general marker for monocytes. And what was really cool is that we tried to do some single cell validation. And in this case, we just use a data set generated by Amit. And if I would just look at the cluster of the single cell in EAE, and this is the cluster of the monocytes, okay? So it's basically those three colors. And if I look at the expression of our marker within the subpopulations, what we're seeing that it's really appearing only within the population of the reactive monocytes, the inflammatory monocytes attacking the CNS. So this is really, really cool. So I mentioned that we kind of want to target it and see what happens. So we generated antibodies, and we have shown they have ADCC and CDC capabilities. And we wonder what will happen if we will administrate those antibodies to the mice, and can we actually affect the disease progression? So we started by giving the antibodies, and what you can see very clearly, and this is the CD11b-CD4 staining, is that when you give the control antibody, monocytes are really here. When we give the reactive antibody, our antibody against this target, the monocytes will disappear. So will that affect disease progression? And the answer is, oh yes. So this is, again, the graph of the EAE score. So it's between 0 and 5. 5 is dead, 0 is healthy, and all the spectrum. And you can see the control IgG really going up. And if you look at the group treated with our antibody, basically almost none of them got sick. And this is, you can see the EAE score. This is the percentage of healthy mice. So declining in the control group, and basically all of them stayed healthy. And if you look at weights to see, is there any side effects? Do we harm the mice? So while the control group really are going down until we have something to sacrifice them, but in the treated mice, there is really no decline in their weight, even a bit slight increase. And this is true also for acute models, also for progressive models. I don't have time to show you everything, but I think it's more strong if you actually look at the mice. So this is the IgG control. This is the control group. I want to show you. Okay, so look at those mice. They are completely paralyzed in the last leg. They look bad. Look at the fur. It's really, really, they don't groom. They're feeling bad. They're really miserable. Look at the control group. Completely healthy. They are moving. They are happy. I want to show this again. All right. Go back. Okay, let's look at it again. Those are completely healthy. Look at their fur. It's beautiful. It's shiny. They move completely free. They're completely disease-free. There's no really any side effects going on there. It's completely, it works pretty, really well. If you look at the pathology behind it, for example, let's look at myelin loss. So this is a staining for myelin loss. You see that in control, you can really see the loss of myelin here compared to the different side of the spinal cord, and you can really see the disappearance of the blue color. While in our treated group, really myelin is perfectly fine. Everybody is fine and happy. So we can say that if we actually deplete those cells, we can really halt disease progression. And what we're trying to do now is kind of see if we can build on it. So for example, we have shown before that IL-10 is a really powerful way of limiting neuroinflammation. But you can't really administer IL-10 to mice or patients. The results will be catastrophic. So we've shown before that, for example, if you can induce IL-10 producing T cells and send it to the brain, we can really affect disease progression. And actually, this is really, really cool because this thing just finished a year ago phase 0 trials. And because we are treating progressive patients, where currently there's no available remedy, we were able to get a special permission from the FDA to treat patients. So currently, there are 2 patients being treated for a year under the Mercy pathway. And in progressive patients, they were paralyzed, they were really in bad shape. One of them returned to walking. The other one is gaining weight again and started walking, and the FDA is currently allowed us to expand those trials and include 10 more patients. And this is going on in Brigham and Women's Hospital, so this is super exciting. So what we would like to do now is actually conjugate IL-10 with our antibodies and see if we can send it to our system, both affecting the ability of the monocytes to function through IL-10, but also affecting what is going on within the CNS, and that will be very exciting. We're currently synthesizing those antibodies. And what, again, we want to do is kind of look at, can we use this also as a diagnostic marker, both by detection of the CSF and looking at, what is going on in terms of conjugating into something we can detect in a PET MRI or different aspects of that. So that should be very exciting soon. So this is my group. This is my funding agencies. This has been done with a strong collaboration with Teva, and basically the main people done this work are Rita and Bao, which are the one heading the GBM project, And Neta and Adi were the one heading this antibody story about the monocyte marker I mentioned to you guys. And if you have any other questions, I will be happy to answer.
Thanks a lot for these exciting stories on glioblastoma and multiple sclerosis. So I also encourage people online to ask questions. I will check. You can use the chat. And if there is any questions in the audience. Joseph. There is a micro. 1 second.
Isn't there any marker for the to use in beta studies for the monocytes?
For microglia cells.
For?
Microglia cells.
Yes.
So there's the PETs for microglia and monocytes, but the problem is you don't know pretty well who is activating. Also, astrocytes will express it.
Okay.
So it's not enough to look at that because you don't know if you have residing inflammation from something else or you have a re-entry of cells into the CNS. And what we want to do is kind of see if we have this re-entry, so indicating a new attack is permanent.
I have another question. With multiple
By the way, with the AL10 treatment for the patients, we really see a decline in those MRI, in the PET MRI of those patients.
With the microglia?
Sorry, you don't see me. With the AL10 treatment I mentioned in the clinical trials, we in those two patients there's decline in the MRI, in the PET MRI of those patients following the AL10 treatment use.
Okay, and in what step of the process of multiple sclerosis would you place the monocytes?
Actually, in all, that's the interesting part. So if you look at relapsing remitting MS, it's driven by the T cells for initiation of every attack, but basically the ones causing the major damage to the myelin are the monocytes. And what is more interesting that in a progressive phase that currently has no remedies, T cells and B cells are quite redundant. Tysabri will do nothing. Drugs can target B cells. We have really minimal effect. A bit about primary progressive, secondary progressive. Currently, there's really no response. And what it seems that in the progressive patient, it's mostly mediated by astrocytes and the monocytes. So actually, I didn't show that, but if we have a progressive model that we can go in different mice, and we can go up to 70 days, 80 days, and we really see an effect there also if we treat in the progressive phase. So I think the monocytes are playing a role in both.
Yeah, this is not my disease, multiple sclerosis, but I find some aspects in the history of disease quite interesting. After many years of focusing on T cells, comes the paper of Stephen Hauser showing that actually the B cells have a major role and has such huge impact in the treatment of patients using, B cell anti-CD20s, etc. So how do you view this process in your research, the role of the B cells in the MS?
So B cells are very, very important to the initiation of MS, and this is actually something that people usually don't know completely, but it's not only about antibody generations. B cells are really, really, really efficient antigen-presenting cells, which is a major role they also function. So if you current remedies, especially the new wave coming that was popping up in the past 2-3 years, are really able to affect relapsing remitting MS, have been shown to affect on primary progressive MS, but they are not affecting secondary progressive MS. So this is really a promising channel, but it's not enough.
There is a question, I think was first Elias and then you.
Thank you. It's a lot of new information for me. I work in diseases a little bit far away from the central nervous system, but immunoregulation and the microenvironment is common to many things. So I am very intrigued about this monocyte CD007. I never heard of them.
It's a temporary name.
I knew CD7, but not CD007.
No, it's a temp name. Basically, the patent, it's just the patent, and
Bond.
I'm not allowed to say the name until
I
the
see,
is applied. So it's like James Bond, 007.
Okay.
Sorry, that's my sense of humor. I
was-
apologize. Yes,
Okay,
it's basically just a temp
Okay,
name.
so it's a molecule that is on the monocyte.
Yes.
So this is an intrinsic property of all monocytes, or a particular subpopulation of monocytes that is going to colonize.
It seems to be the classical monocytes, and the most pro-inflammatory monocytes express the highest amount.
So it's not something specific of the monocytes that are going to go to the central
Not
nervous.
specific to the monocyte that will go there, but it's specific to the monocyte that will be found there. So those are the monocytes that will eventually come to the site of inflammation. But it's, they can go to other inflammatory sites, and that's why I mentioned in a side note that we are seeing the same thing also in Parkinson when you have monocyte migration. We see that in the tumor microenvironment when you have monocyte migration. So I think we haven't even showed that a bit on stroke. So we kind of see it in every model when you have inflammation coming in. We are also were able to detect in single-cell analysis of COVID patients that those monocytes will also be accumulating in the lungs of COVID patients during the...
That was the question. It's not something that brings the monocytes to the central nervous system. So
No, but
it could be...
being a neurologist, yes, it can be used for other things, but as a neurologist, for me, it's a really precious tool to attack them once they come in, or to target things into the CNS.
And the second thing is related to the other side, the interleukin-10, because I am reading more and more on that interleukin-10 in the response to lymphoid neoplasias. And I see the results in some studies like a little contradictory. In some situations, interleukin-10 seems to act or play a role like immunosuppressing the microenvironment, probably stimulated by Tregs. But at certain points, it also seems to act as promoting certain cytotoxic activity. It seems that it may play a dual role depending on the moment of the inflammation that is acting. For instance, it seems that it's able to promote a precursor pre-exhausted cell to a more terminal differentiated cell with more cytotoxic activity, but prompt to be exhausted. So depending on the moment that I see interleukin-10 is acting, might play a dual role.
So,
and I think here, I guess you are exploiting the role as an immunosuppressor of this reactivity.
So there were a few studies already that have been used to induce IL-10 in the CNS. Some people use viruses to express it. We use specific T cells that can express it with blocking antibodies against the IL-10 receptor, and et cetera, et cetera. And the virus is targeting the IL-10 receptor in the brain, different cell types. So far, all the data we have about, at least the one I know, about neuroinflammation and IL-10 suggests that IL-10 is able to quench inflammation and kind of support remyelination. Although it's not sure if that's a direct effect or just a side effect because it stops inflammation. We haven't encountered yet in the CNS that response. I know it can be found in the body, in the periphery, but that's really something important that we'll have to kind of explore once we go with this treatment and see what will the effect will be. That's very interesting.
What I understood, is all this is a new field.
That's a problem with IL-10.
Exhaustion of the
IL-10 is
I am
really...
thinking of reactions against tumor. That's what the exhaustion of the T cells.
I know that there was also a recent paper then they conjugated IL-10 into, I forgot which antibody, and they used it to treat tumors, which was pretty interesting because I thought it would be the opposite. I thought that if you give IL-10 to the tumor microenvironment, you will not see any cell death. You will see the opposite. You will see more immunosuppression. But yeah, this is really, really interesting, and this is something that we will have to explore because so far the delivery was very, very difficult to do, and I hope we can actually kind of modulate that. What can we also do is kind of also see if we can add different linkers that will allow the IL-10 to be released only in the inflammatory environment, and etc. So this is something that kind of will have to be a work in progress. But that's a very interesting thing. I mean, ALT10 is fascinating. The brain is saturated with TGF-beta, so TGF-beta has really minimal effect on the neuroinflammation, but ALT10 is a completely different story.
And just a final question, more from the newspapers and the literature is, what about this story of EBV and multiple sclerosis?
So actually, I mentioned we have the NAD Krebs Cycle story. That's with Larry Steinman. Larry Steinman was the one who published the EBV story. That's kind of fascinating. Larry's data seems to be extremely strong in that correlation. I know that a lot of people have now been trying to look at the EBV signature in B-cell receptors and T-cell receptor repertoire to see if they can see any correlation. But I, was just meeting with Vijay and Francisco Quintana and Weiner last weekend. And so far, there's really, it's really in progress, but it seems to be, the data that Larry published, it's very, very strong. By the way, one of the molecules, the glial CAM that he's talking about, that is connecting the two, is expressed highly on astrocytes. But this will have to be established and further verified. But this is really, really fascinating. If you don't follow, so basically, the concept behind autoimmunity is kind of the molecular mimicry. So we assume there's some sort of inflammation, maybe caused by a virus, that will cause the body to start reacting against this epitope on the virus. That is also found on human cells, and that's why basically we break the body tolerance against self-antigens. And people have been looking for many, many years for different viruses that they can do that, and EBV were actually postulated to do that before, but it never mounted to anything. And about half a year ago, Larry Steinman and another person from Stanford published a paper, with a huge data set from the soldiers showing a really clear correlation between EBV infection and your probability to be an MS patient. So that's really something that was kind of stirring the field again, and now we try to figure out what to do with it. And how can we use it as a way to manipulate the disease.
Thank you.
One more quick question.
So quickly, what's the next step with the ABCA1 story? Is there a specific inhibitor that you might use?
So with the ABCA1 story, this was actually patented a while ago. And so what we're trying to do is basically three things. One, there is a drug that is able to affect its expression. It's been used for other diseases, and the problem is that it has a very high safety at the moment. So the company is refusing to try to repurpose it because GBM is a very lethal disease, and they don't want to have a correlation of this drug with cases of death. So they refuse our suggestion to repurpose it, which I found extremely annoying. Another thing we are pursuing is statins. So statins can lower cholesterol. The problem is that many statins will not cross the BAB. And getting the, by the way, if you can help with that, that would be great. We're trying to get information about GBM patients who were treated with statins to see if we can find some correlation with the statin that will go into that can actually penetrate the blood-brain barrier. And we are also talking with some neurosurgeons to see if we can, once they actually take the tumor out, and if they can put some statins in the tumor bed to see if we can affect it. Third is that the problem with GBM is that even if you take the tumor, the margins will always grow back. Now, one of the good things about our system is that it's based on astrocytes and monocytes. And astrocytes and monocytes will always know where GBM is present. So they will, the astrocytes will express the ABCA1, and the monocytes will actually go there. They will go to the margin of the tumor, no matter how small it is. So what we found that we can express a protein that is able to degrade LDLR, the receptor for cholesterol on the GBM cells. And if you use lentiviruses to express this protein on astrocytes, we are able to degrade LDLR on the tumor cells and kind of start killing them. So this is something that we're trying to do now. And to find if anybody wants to kind of synthesize a molecule that will inhibit ABCA1 and can be delivered to the CNS. So there's different balls in the air, and let's see what will fall.
I'm wondering that the target, James Bond, is it the same in mouse and humans?
Yes. We've been shown, well, using RNA-seq, that other people have done, that it's not found in the CNS, not in mouse and not in the healthy CNS, not in mouse and not in humans, but it can be found in MS blocks and in other diseases. And one of the things I was really happy about they're having this pathology core here is that they have MS samples, so I can finally do some verification in protein level for that, because this was a major disability that I couldn't find any MS tissue to work on. So they actually have MS and PD and other things here that we can hopefully be able to collaborate with them and get a sample so we can do the analysis and also show it in the protein level and not only just using the RNA-seq data.
So rather than antibody, can you use like
Small molecules?
No, like CAR approach to target that? Yeah.
Theoretically, yes, but one of the things that we found is that we have to keep it in a very low affinity. So our ability to obtain the effect I showed you is dependent on a very low dose of the antibody, so and very low affinity of the antibody. So we are really targeting and
What do you
killing.
mean low? What's the range of low?
Yeah, let's not go into that. But we need to affect cells that express very high levels of James Bond. And if we just give too much, that can be a problem. So I'm afraid that with CAR T cells, they are so potent that I'm afraid that the effect will be just too strong.
But also for the IL-10 deliveries, I mean, that's also.
The alternative, that could be cool, actually. That could be very, very cool. We try to do that with nanoparticles, but they don't really go.
With the CAR approach, now they combine the CAR and the cytokine together.
So we tried to do it with nanoparticles. It didn't work really well. They didn't go well to the CNS in autoimmunity, and it didn't really. We were not able to affect. They didn't go where we wanted them to go. So it didn't really do the trick.
Okay, thank
you
you
very
so much. We move on now to the second talk and the last one for this session. It's a pleasure to introduce Dr. Giuseppe Dalmau. He leads the group on pathogenesis of autoimmune neuronal disorders, so close interest to Lyot. And I like his quote in his webpage: "In neuroscience, as in medicine, nothing is more exciting than to discover a new disease and try to understand its physiopathology." And that's actually what this group has achieved in the last year. So thank you, Giuseppe, and I leave you the floor.
Well, thank you very much. And thank you for inviting me to give this talk. I think it has been a great session of talks. And yesterday, Dr. Elias Campo was talking about translational research, and I'm very interested in translational research. I am a neuro-oncologist, and I'm not a neuroimmunologist. So I'm going to talk a little bit about a story that associates neurology, cancer, psychiatry, and molecular mimicry, all part of the same story. So it's a single story that has all these components. And basically, cancer can affect the nervous system in many different ways. So you have primary brain tumors, and then you have metastatic complications, which is by far, if you are a neuro-oncologist, by far the most common problem is metastatic complications of cancer, much more than primary brain tumors. And then there are the non-metastatic complications of cancer, which if you are a neurologist, is like a parallel world, right? Because the complications that you have in these patients, iatrogenic or metabolic or infectious, are not the same ones of coagulopathy as you see in patients without cancer. But there is one group of patients that have these disorders called paraneoplastic, which are quite fascinating. So the paraneoplastic syndromes, neurological syndromes, can affect any part of the body. Neurological syndromes is the one that I'm going to talk to you today. actually I'm going to talk of something else, but this is an introduction, are interesting because they manifest first and before you know that the patient has cancer. So it has a value to recognize these disorders because you can treat the patient or you can identify the patient at very early stages. They are difficult to diagnose. They are more debilitating than cancer, and are mediated by immunological mechanisms. So when I studied here in Barcelona, this is many years ago, I studied medicine. In this hospital, I talked to you about this hospital yesterday night, this Sant Pau Hospital, and the architect is Domènec Montaner, who lived by the same time as Gaudí, and I think it's as good as Gaudí. No relation with him. So when I became interested, there were neurology and there were oncology. There were very potent services in this hospital. As a consultant, I became fascinated about cancer, neurological complications. So at the time, there were no neuro-oncologists in Spain, and barely there are now. But this moved, led me to move to Sloan Kettering in New York. So what you see here actually is Sloan Kettering is here. Wait a minute, how I do that here. Sloan Kettering is here, Rockefeller University and Cornell. So it's a quite very interesting three institution area. So I went there with the father of neuro-oncology, Jerome Posner. And before arriving there, I was going to go for 1 year to do a clinical fellowship. The laws in the US changed, so I couldn't do a clinical fellowship. I couldn't see patients. So Posner told me, if you come, you have to go to the lab. So this is how my part of research in my life started, just because of a stupid law. And at that time, Posner was very interested in these neurological complications, paraneoplastic. The idea is that the cancer expresses a neuronal protein, induce an immune response, which sometimes can be quite effective against cancer, but is misdirected against the nervous system. So there are several ideas here. Leo commented before about mimicry. Well, yes, this mimicry, actually. And at that time, this was a rare field of research, although neurologists have always been fascinated in these disorders. But now this has become center stage, particularly with immune checkpoint inhibitors that unleash these immune responses that are sometimes subclinical. And so what we said 40 years ago or 35 years ago now is emerging again. So these disorders have antibodies, and these antibodies, of course, attack the tumor, attack the brain, are against proteins of the tumor, are against proteins in the brain. It's not that they attack, because more of these proteins are intracellular. And here you have some of these antibodies associated with some of these syndromes. But the real effectors is not the antibodies. The antibodies are good biomarkers, and you can use them as a biomarkers in clinic. But the effectors in this group of diseases are the T cells, okay? These are antibodies of patients reacting with the brain of rat, for example. This is what really happens in the brain of these patients. Actually, this is dorsal root ganglia, 2 large neurons, but this neuron becoming degenerated or killed by T cells. All of these are T cells. And this is in the CNS, and you see also the same phenomenon. You see neurons indebted by T cells, okay? Now, this is devastating. This group of diseases are devastating. Still now, after so many years. This is the autopsy of one patient with cerebellar atrophy, but this is what happens when you look at the atrophy, and this is not selected. I did this study, actually. You usually look at the entire cerebellum. You don't find a single Purkinje cell. You find 2 or 3, okay? And this is a normal cerebellum, all right? So this was the first part of my life in research. And we always wondering, well, all of these are devastating diseases. There are diseases in the brain mediated by antibodies, because these antibodies are biomarkers. They do not penetrate the cells. These are intracellular proteins that are presented on the cell surface, and actually the real effectors are the T cells. But there is another paradigm of disease in the peripheral nervous system. These are the myasthenic syndromes. For example, in Lambert-Eaton myasthenic syndrome, you have, well, this is the synapse, the neuromuscular synapse, the end terminal, the end plate, sorry. You have here the muscle, you have the acetylcholine receptors, and presynaptic calcium channels, right? So these patients with the Lambert-Eaton myasthenic syndrome develop like myasthenia gravis. It's not the same, but more or less reminds a little bit. They develop antibodies against calcium channels. Of course, these antibodies against cell surface. And if you treat these patients, they really recover. If you remove the antibodies or the cells that make the antibodies. And on top of this, you know the physiopathology, you can also block the potassium channels, and you see that also ameliorates the symptoms. So is this happening in the CNS also? See, this was the idea in this field, or the question in this field. And in 2003, when I spent 11 years at the Sloan Kettering, but then I was at Penn. When I was at Penn, they consulted us by a patient that this is not the patient, but very similar. So the patient had been in the ICU for several months, and the patient was in this status, was ventilated, had nutritional support with a nasogastric tube, and the patient was in like a catatonic state, did not communicate with anyone, did not recognize family members, and could be like this. She was there for about 2 months in the ICU. And we were consulted. We had no idea what the patient had, but she had the 2 million tests, and all were negative. And eventually, empirically, it started to improve after treating her empirically with steroids. She had a tiny ovarian teratoma. Again, this is not the patient, but it's quite similar. So this is the same patient after, you can see after several months, he is very deconditioned, very thin, recovering. And this is the same patient months later, fully recovered. Now, from the neurological point of view, there are basically, when you have a patient in the ICU for 2, 3, 4, even 6, 7 months, it's very difficult that these patients recover to integrity. But this happened in this patient, okay? So this reminds, let's see if I can do that. This reminds me of similar patients in that we were consulted. This, the first patient, similar to the one I show you, had 26 years. Remind me 3 other patients. They were identical, copycats, perfect. They presented with acute, rapidly progressive encephalopathy with psychiatric symptoms. Psychiatric symptoms were very important, and we put this in the title of this paper. And they were severely affected, hyperventilation and all these symptoms, and also developed all these neurological problems, abnormal movement, seizures, and so on. And all 4 had also a tiny ovarian teratoma. An ovarian teratoma is a very small tumor, could be very large. It's a tumor that contains the 3 germinal layers there, and they're also nervous tissue, okay? And particularly in these patients, we didn't pay attention to the ovarian teratoma. It was a tiny tumor in a patient that was full of tubes in the ICU, and it's benign, so you're not going to take it out. All right, then we realized that there is a link there. So after months, that now is ridiculous, and I'm going to tell you how many months, we figured it out. All the tests were negative, all the antibodies were negative. We had to make changes in the tissue, these sagittal coronal sections of rat brain, to see that all 4 patients had an identical reactivity of rat brain. And when you use live neurons, all 4 patients had antibodies in CSF and serum reacting with the cell surface of neurons that you can see here, like dot-like stain. These are clusters of neurons, clusters of whatever, receptors or proteins, we didn't know. We figured it out that these were the Nmda receptors that were critical. It's a glutamate receptor, critical for synaptic transmission, for brain, for behavior, for memory, etc. Okay? So we named this Nmda receptor encephalitis, and this has started a new era in this field of cancer or non-cancer related disorders in that there are antibodies associated. But this is a new era. Compared with the classical paraneoplastic syndromes that are devastating and the antibodies are there, by the T cells are the bad guys, in here, the antibodies are biomarkers, and in here the antibodies are effectors and react with the cell surface, react with epitopes exposed on the cell surface. And if you recognize that, you can treat and cure the patients. So since 2007 until now, there are 15 additional disorders. We identified 11 of them. And I'm going to talk today a little bit more about the Nmda receptor because it had changed paradigms in many ways. And I'm going to talk to present some examples to tell you how this had changed fields. There are antibodies that affect your memory predominantly, antibodies that affect your sleep. And I'm going to talk about this, not about all of them, but about concepts. So here is put another way, and some of them associate with tumor, but not all. This breaks the paradigm of the paraneoplastic syndrome. So some of them, the trigger is a tumor, and you can see here the list of tumors, sometimes malignant, sometimes benign, or sometimes there are no tumors, and the trigger we still don't know. And each one of them associated with a different type of syndrome. Sometimes different antibodies turns out to have a similar syndrome. I'll talk about this. The Nmda receptor is special. It defines a new disease. Everything is new there. So this is put in a slide. A psychiatrist friend of mine put this slide many years ago when we worked together at Penn, and it's impossible to make it better. So I repeated and repeated. It's in books, it's in the New England, and I think it's genial. The guy is a complex disease, and the guy had this great idea to summarize this here. So patients usually present with a viral-like syndrome, and there's a little bit headache or like a little bit of fever for a few days, and then they become, many of them, frankly psychotic. You cannot differentiate these patients from a psychotic break from a primary psychiatric disease. Luckily, many of them develop neurological problems. And then the psychiatrists usually call a neurologist, or psychiatrists usually transfer the patient to the ICU because the neurological problems become severe. Abnormal movements, autonomic dysfunction, coma, hypoventilation, seizures. Then you treat the patient here with immune therapy, and if they have a tumor, remove the teratoma, and they start to improve slowly, sometimes for months. And in here, the patients look much, much better. But when you start examining the patient a little bit better, carving a little bit on the surface, these patients have still prominent cognitive and psychiatric dysfunction. And this is an area that we are now actively studying very much because this is the area that fascinates me. We have solved a little bit this, but not this area here. People don't know what to do with these patients. You send them home because they are no longer in the ICU. All is resolved. They don't have any more seizures. They have this temper, lack of concentration, memory deficits, and psychiatric dysfunction. So we try to understand that better. And this was actually one of the topics of the grant that we defended yesterday. So just an example, this is how one patient presented, all right? So I got this email one day from a lady that lives in Canada thanking me for identifying this disease, and I never met her personally. And she was saying, oh, my husband had the disease, and this is how it started. Remember that starts sometimes with psychiatric dysfunction. So the wife found this patient that, by the way, is not a chemist or physicist or mathematician, is a veterinarian. So she found him one day at home with all these stickers around the table and around the walls, and he was designing a flying car using nitrogen gas to float against CO2. And you see the car here from the top and taking off in all these sort of psychotic break presentation. They develop all these other symptoms, and the patient improved after the diagnosis and treatment. These patients, so the question that I always have, so what happens before? Well, these patients before died, or before they were misclassified, like even some autopsies that we have studied in retrospect and examined sometimes the samples, the serum and CSF archived, frozen. Even the autopsy studies, encephalitis likely viral induced, but without viruses identified. So this is a collaborator from Japan, and he sent us, after reading the original papers, he sent us 4 cases of 4 Japanese people that they have seen many years before, but the Japanese keep everything recorded. It's wonderful to work with them, have all the material, and if you ask them, and you are in Philadelphia, the FedEx arrives from Japan to Philadelphia overnight, okay? So if you are in Spain, it takes probably 2 weeks. So this is the patients that they did not identify, but they have the syndrome in mind, and they thought that this was viral induced. And this patient, for example, spent 9 months in a hospital, and 9 months with ventilation, 14 months in the hospital, and then basically recover with empiric treatment. But not all of them were so lucky. Some of them died, not in this study. Another patient was under mechanical ventilation for 7 months, 9 months in the hospital, and went back to work later. This is a physician, actually. And so this is what happens before. So the patients were in the ICU. If they are children, the same phenotype is there. I told you about abnormal movements. Okay, what is an abnormal movement? Okay, in this disease, these are abnormal movements. Okay. So in this disease, you see that it's also with a nasogastric tube, and they usually present with alterations of behavior. And so the patients that I told you before, they also have these movements, and this is the patient after treatment. Right? So what it was thought to be a rare disease, and is defined as rare disease and fulfills criteria of rare disease, is not so rare. So in a study that we published a few years later of 577 patients, we saw this profile in the patients. They are usually younger than all the classical paraneoplastic syndromes that usually are in this here, but they're usually younger. The median age is 20 years, okay? And what you see here is women, pink, women without tumor, in red, women with tumor, which is almost always a teratoma, and of the ovary. And what you see here, the blues are boys or men, and the very dark blues, men with tumor. And the younger the patient, they're less likely to have a tumor. The antibodies are directed against an extracellular domain of the gluon 1 subunit of the receptor. So it has 4 subunits, 2 gluon 1s, 2 gluon 2s. I just represent only 2 for simplicity. And the antibodies react against this specific region here, which is not the ligand binding region. The ligand binding region is here. This is a regulatory region. And the patients get better but very slowly. This study, this larger study, at 24 months, basically, many of the patients have substantially recovered. This is in a scale that 0 is no symptoms, 6 is death. 80% have substantially recovered. And you obtain this treating the patients with immune therapy, a combination of treatments, and sometimes with more stronger, let's say, put it this way, immune therapy like eliminating the B cells, rituximab, sometimes more harsh treatment like cyclophosphamide. And the disease relapses, but this is not MS or aquaporin 4 type of disease, in that the relapses are much more frequent. This is less. You actually treat these patients well and intensively in the first presentation, and many times they don't have relapses. Okay. So at some point in my life, after seeing for many years patients with brain tumors, complications of cancer, and I make a decision that I was interested in these diseases. We had identified a number of them. So I decided to be at two places. I decided to be in Barcelona, and I decided to stay in the US. And ICRIA, which is Catalan Institution for Research and Advanced Studies, this is an institution that has the highest density probably of ERCs in Europe as institution-wise. So made this possible. And on top of this, I give you a lot of freedom, which I needed. I love the United States. I am a US citizen. My wife from United States, although she wants to be in Barcelona. And, but they have limitations. They have a lot of advantages in the research, but they have a lot of disadvantages in the healthcare system. So I tried to find this balance. In Barcelona, and there, we move on towards the pathogenic mechanisms of the disease. And this is the similar fascination remains here, or even more than in the clinical side. So why these patients have this disease, and if you think that is antibody mediated, why they don't get better so fast as patients with myasthenia gravis? We don't know yet, but we have some theories here. First of all, look at what happens when you compare the antibody titers in CSF and serum. And you have much more titers in the CSF or in the brain than in serum. And this is what you see in the brain of the patients. All of these are plasma cells in the brain of the patients. When you examine these patients, well, I'll show you about this in the next slide. And these are plasma cells in the brain of patients. Of course, this is not model. Now we are going back to the patients. And you know, plasma cells are good factories in making antibodies, and same as memory B cells, but these are plasma cells. So what you see in the autopsy is fascinating. This is very recent, and one of the patients was from Barcelona. This was done by a Viennese pathologist who spent some time here with us. She's a very good pathologist. And so what you see is all these components of B cells and plasma cells in the brain with very, not too much T cells. And the T cells are not, when you see T cells, they are not like in the classical paraneoplastic syndromes indenting neurons. These are T cells that are there as part of the immune response, but B cells. But, and of course, there is always microglia activation. But what's interesting is that when you quantify neurons, you don't find neuronal death, basically. Neurons are dead, are there, and appear to be alive, of course, until the patient died, but are there. And what you don't see is the expression of an Nmda receptor compared with a control brain. It's a brain of an individual who died, didn't have this disease. So in brown, you see that there are no Nmda receptors. So how this, wait a minute, what happens here? So how this happens? Jesus. Okay, so the way that this happens is that the antibodies bind to the receptors, internalize the receptors, and there is cross-link and internalize the receptors. And so there is a dramatic decrease of synaptic Nmda receptors. If you use the Fab fragments from the same patient's antibodies, you just use the Fab fragments, they bind to the receptors. And you see this by immunohistochemistry, you're going to tell the staining is the same, but they don't cause any effect, okay? And if you ligate the antibodies, again, with a piggyback-like type of construct here, simulating an antibody with two arms, you recover the pathogenic mechanism. So this was demonstrated, this is here a cartoon, but this was demonstrated in a paper. So what you see here is in cultures of neurons exposed to these antibodies, all of these is a dramatic decrease of the clusters of Nmda receptors compared with neurons treated with a CSF control without the antibodies. And you see these amplified here at the bottom. And you can quantify these, and you see this dramatic decrease of receptors. And when you remove the antibodies, there is a reinsertion of the receptors in the synapse, as you can see here. These are neurons that were treated with the antibodies. You remove the media, fresh media without antibodies, and you have the recovery. And this is highly specific. So you don't see these effects if you look at other synaptic protein like PSD95. So the question is, okay, we identify the disease, we identify the antibodies, we identify what the antibodies do, more or less the pattern of the disease and how to treat them, more or less, and there's a lot of room for improvement about the treatment, but do the antibodies cause symptoms? So for this, we use a passive transfer. Now we have an active immunization model that confirms this. But these were the initial experiments. So we put mini-osmotic pumps filled with CSF of this patient enriched with antibodies. And these pumps, for 14 days, infused the antibodies in the brain of these animals. We didn't like to put this in the brain. We put it in the ventricle. So for 14 days, the antibodies are infused in the ventricles and diffuse around it. And in the brain of a rat, basically, more than half of the brain is hippocampus. So we focus in the hippocampus. So what you see here is animals sacrificed at different time points, and you see the building up of the patient CSF in brown compared with the controls. And what you see is that these animals during these days, they are happily in the arena there when you examine, they have this dramatic decrease of memory that when the pumps stop, they recovered. And these are the controls. And you see that these animals, not shown here, they can also develop psychotic-like behavior with a prepulse inhibition, and you also have problems with anhedonia. Okay, so the antibodies, yes, cause symptoms. But the antibodies alter in the animals, also alter the Nmda receptor. Yes, you see here this is also for simplicity. We check multiple areas, but you see here this area with a dramatic decrease of the clusters of receptors compared with the control. We have used the model now to test for treatments, the same way as I show you with the lamberton, that you can approach the model with immune therapy, but if you block, remember the potassium channel, there is also a facilitation of release of acetylcholine with the lamberton. Okay, so in here, if we understand the mechanism, we can use, for example, an allosteric modulator of the Nmda receptor to try to overcome the antibody effects. And this is the same model as before, repeated all over, but the animals were treated with an allosteric modulator of the Nmda receptor. So these are the animals, different sets, but that as in the previous one, they show this dramatic decrease of memory. But these in blue are the same, are animals treated the same way, but, so they receive the antibodies, but treated simultaneously with an allosteric modulator of the receptor. And you can see that abrogates completely the memory deficit. It abrogates completely also the alterations of the antibodies. In this case, it's a long-term potentiation type of paradigm. You see that the antibodies abolish the long-term potentiation development, but the animals that receive the allosteric modulator abrogate this effect. And this is also seen here. The antibodies, as I show you several times, decrease the receptors, but if they receive this allosteric modulator, which is a brain derivative cholesterol compound that is a very potent allosteric modulator. This is done with a company in Cambridge. And then you see that abrogates the effects. Of course, it's a cholesterol derivative, so you don't have any problems in administering this subcutaneously. And even there is a pill that is in a clinical trial for another disease. I mean, it can give even orally. So this had changed a lot of paradigms. Imagine, so you have a disease in that the patients develop positive and negative symptoms of psychosis, okay, which defines basically a schizophrenia in some ways, is one of the criteria of a schizophrenia. Now, there are animal models of psychosis in the field of psychiatry that depend on the reduction of Nmda receptors using genetic or pharmacologic modulation. So now you have also an animal model, not only a disease in humans, an animal model that if you decrease the receptors, they behave almost similar as these models in here. So in some way it has revolutionized a little bit the field of psychiatry and neurology. I'm going to skip this a little bit for this is area that we are involved now in research. And we have developed paradigms with neurophysicists here, even very simple ways to check the working memory on these patients and psychiatrists, in psychiatric patients. I'm going to skip this, but we can go back if then you have questions. These are tests that we develop, like very simple touch to a screen test that can be done, remotely to assess some paradigms in the behavior cognitive function of these patients. Another group of diseases is limbic encephalitis. This is very different from this one. And in this one, the immune response or the antibodies target the limbic system. You can see it well, the flare changes in the medial temporal lobes. What is the symptoms of these patients? Well, it's predominantly a severe memory deficit, shortened memory deficit. So these patients don't remember anything that I said starting like probably 2 or 3 minutes before, okay? You don't remember, they don't form new memories because the hippocampus is involved, is this area of the brain in that receives all these experiences and after this contributes to the forming of long-term memories. So this is dramatic. When you have one of these patients in practice in the room, there is no way to get rid of the patient. Because every time that stands up to go to the door, he turns around and asks you the same question. Or the patient can be reading the same page forever. This is the Henry M. type of a story in the field of psychology, is the classical Henry M. There was a psychiatrist that in 1953 removed these areas that are here so enhanced, removed these in Henry M., Henry Molaison, removed these to treat this patient for epilepsy. So he did not have any more epilepsy in the rest of his life, but he did not remember, he remained frozen in time. So there are immune responses that cause this, and you can treat them. And the antibodies are, we identify actually all three. The antibodies target this protein, or this one, or this one, the Nmda receptor, the GABA-B, or the LGI1. It's not only clinical observations, but there is a lot of research done here also, and in collaboration with other people in Europe, showing that the antibodies for each of these disorders have different effects. Not all the antibodies bind and internalize receptors. The Nmda receptors do that. This is what I show you. The AMPA antibodies do that, but not the LGI1 antibodies. In fact, this is a protein that is in the synapse here that is secreted and forms a bridge in the synapse, and the antibodies disrupt this bridge. And in case of the GABA-B, it's a metabotropic receptor. So the antibodies go and bind to the ligand region and block the ligand binding. So what triggers this disease? I have 5 minutes more. Yeah. What triggers this? What triggers this disease? Well, it's fascinating. I told you there are tumors that trigger that. Let's go back to the Nmda receptor encephalitis. About 50% of women, if they are teenagers, in some ethnicities, not here, not in Europe, but in the US, particularly if they are African American or Hispanic, about 50% have an ovarian teratoma. In here, this is probably 20%. So the tumor has spontaneous apoptosis. Dendritic cells probably present the antigen in local regional lymph nodes. And remember what we found in the autopsies. Now, this was put together years ago for a paper, a review that we published in the New England. But remember that we have in the autopsies, you find in the autopsy of these patients a lot of plasma cells. So what arrives to the brain is not the antibodies. Probably antibodies arrive also. But these are most the B cells that they undergo re-stimulation, antigen-driven affinity maturation, and probably progression to plasma cells making the antibodies. So this is one mechanism, and the antibodies then they cause the alterations. There is another fascinating mechanism that is much rare, but this was identified here also by Thais Armanguet, who is a neuropediatrician, who works in here, and remember yesterday, San Juan de Deo, she works in both sides. So patients with herpes encephalitis, you know, it's a severe disease, it's a very neurotropic virus, a lot of inflammation, and patients with herpes encephalitis develop an autoimmune encephalitis that sometimes associates with antibodies against, sometimes not very frequent, with antibodies against the Nmda receptor and others. So it's not only against the Nmda receptor. So what we think it happens in this disease is, in these cases, is that there is an antigen presentation in the local regional lymph nodes, deep cervical lymph nodes, which are the local regional lymph nodes for the brain. You know, remember, brain has lymphatics. When I studied medicine, brain did not have lymphatics, but we know that has lymphatics. So this study, and this is what it shows in the study, and this is really very important because this, all of you, if you are involved in patients, you actually could see these patients, or you are seeing these patients. So this is a study that was done with 51 consecutive patients with herpes encephalitis in 90 centers in Spain, okay? So what happens is that this is day 0 of the herpes encephalitis. They don't have antibodies against the nervous system. Then you treat the patient with a cyclovir, and standard of care is after 21 days you stop the cyclovir, you do another spinal tap. And what we realized actually is that 14% of these 51 patients develop a second wave. And this second wave, when you do the PCR, is no longer positive for herpes. And when you examine the patients here clinically in this second wave, basically almost all of them had antibodies against the Nmda receptor or against other neuronal proteins, sometimes both. And then this is long-lasting. The cool thing, remember that I told you that by patients get a spinal tap on day 21 when the cyclovir is discontinued. But what this spinal tap showed is that even before showing the symptoms, you can already identify the antibodies here. You can predict which are going to cause that. Now this is 27%. It seems this is very high. It is. And this has been reproduced. And this has been going on. Now we have more than 100 patients. And this is important to recognize because in the clinic, in the real world, these patients have a devastating disease. They send home many times to rehab centers because of the damage in the temporal lobes by the virus. Everything that comes after in the real world is blame the virus. So had this terrible disease, so this alteration of behavior or neurological problems is a result of the virus. Yes, sometimes not. And if you treat these patients, you really make a difference. Now, as another trigger, you can ask if there are genetic factors behind that. Well, not for an Nmda receptor encephalitis. This is not very strong. For some others, yes. And I want to finish my talk with this one. This is the perfect model of translational research in here. So this is Iglon 5 disease. And I told you that we're going to talk many things as part of the same history. So here, if I had to put a title, it's autoimmunity versus neurodegeneration. So here's the story here. Our friends and colleagues in the Department of Neurology in Sleep Center, which are very good, they see a patient one day that had an abnormal type of a sleep. And they say, well, this is, we never seen that. This is different. And this patient has a complex problem of not only REM, but also non-REM sleep, particularly at early stages of night. And then as the night goes on, this recovers. But if the patients wake up, they have, again, the same problem with alterations of sleep, these abnormal movements. So this is a patient in a stage of sleep that should not be moving at all, okay? And has these finalistic movements like drinking or eating. Anyway, these and all have these. So, and they say, we don't know what it is, but probably it could be something related with Casper antibodies that it's probably not, but let's check. And they sent us the CSF of the patient. The CSF of the patient has this remarkable reactivity with the cell surface of neurons. To make the story short, the target is IGLON5. Nobody has any clue about IGLON5 is. It's a protein in the synapse, probably involved in axon path finding, and there is a very strong association with GLA typing. Different from all the diseases that I show you, this is chronic. So this is mainly of sleep, is chronic, have these antibodies, and chronic means for many months, and they don't respond to treatment as well. They actually die, many of the patients, of brainstem dysfunction, respiratory problems, stridor. So this is how some of them present. Not all present with sleep, sometimes with bulbar dysfunction, with a PSP-like phenotype, cognitive, but all of them progress towards the core of the sleep dysfunction. The surprise is when these patients die, what you find is a new type of accumulation of tau in the brain, tau. Mainly in the hippocampus, in the hypothalamus, hippocampus, and dorsal brainstem. And this is a distribution of tau. If they die very early, now we realize that they don't have tau, they have some inflammation. When it's a chronic disease, when they die late, they have tau and they don't have so much inflammation. So now what is first here? Is the egg or the chicken here type of a story here? Is that autoimmunity cause a neurodegeneration? Of that neurodegeneration cause autoimmunity? In favor of this is the height-specific antibodies and the strong HLA association. Remember that narcolepsy has a very strong association. In favor of this, that it has a chronic course, and that there is deposits of tau, and there are absent pleocytosis there. So the balance goes to our understanding to autoimmunity right now. Because when you do these paradigms and cultures of neurons, and you expose the neurons to the antibodies of these patients, they cause an irreversible internalization of IGLON5. It's irreversible. It's not reversible like NMDA or AMPA or any, and this is the control, the one at the bottom. Now, this is what the antibodies cause. Not only decrease the IGLON5, but change actually the cytoskeleton of the neuron. And you have all these alterations in the neurofilaments, like these bundles, ring-like, early termination. And there is new evidence that this ends towards accumulation of tau. But this is very preliminary. And it's very intriguing disease. I show you how autoimmunity in patients, okay? My research also starts with patients. And I show you that there is a new category of diseases you can call autoimmune synaptopathies, autoimmune encephalitis, mediated by antibodies against neuronal surface proteins or receptors. They have changed the paradigms in medicine, I think, and not only in neurology and psychiatry. And the antibodies alter the structure and function of the target receptors, leading to symptoms. Knowing the mechanisms, you can treat the disease with immune therapy, but sometimes you can get advantages with some other treatments beyond immune therapy. And this is a new field of research. So there is a whole area that you can expand here, knowing better the syndromes. The immunobiology is it needs a lot of work in the area of immunobiology. We need work in biomarkers and disease models. Well, thank you very much. All the people involved here. Go ahead.
Fascinating indeed. I'm wondering, did you check if these antibodies bind to the glycosylation form of these receptors, maybe the glycosylation is just joined across the different receptors?
Yes, there, there has been some work on that, not too much. For the Nmda receptors and for some other disease. The disease that has looked more is a very rare disease that I didn't talk today, and that is heavily glycosylated one area. But the antibodies bind also after taking care of the glycosylation. With others, not. For others, it has not been looked at. For the Nmda receptor, the same. It's actually independent of the state of the glycosylation, you find the antibody binding. But you can argue, well, perhaps, this is the Nmda receptor is focused in a few types of epitopes only in the area that I mentioned, but there are perhaps some antibodies against close epitopes that are against glycosylation sites. We don't know.
We can check that. Just a clue.
So that's what is good.
Sounds like sciatic acid.
That's what is good. This is a direct answer question.
We have one line now, collaboration now.
Go ahead. Oh.
Go ahead, yes.
Fascinating talk. Thank you very much. So you've convinced us that the antibodies are the bad guys, and therefore the B cells and plasma cells that make them. But can it be that they are also markers and T cells are also involved, being that the B cells are also APCs?
Yes, that's the area of research. There's an extra step that many groups are taking this path right now. Yes, that's the new area of research. And particularly, it comes also from the association with HLA in some of these disorders. So for the Nmda receptor encephalitis, and for many of them, it's like really a B cell mediated. It's like myasthenia gravis, right? It's like a B cell main B cell mediated disorder. In that, of course, the T cells play a role, obviously, in the activation of the immune response. We need T cell biologists here, so I'm just trying to capture your interest.
I've noticed that in one of the graphs that you showed that there are more females than males, and also, there's an age-dependent, anything with hormones, and also teratomas in ovary. So everything was pointing to something that has to be with the hormones related.
Yes.
Estrogen. I don't know. I'm just pointing out.
No, you're pointing to the you're pointing to the right direction. Yes. No, it's. I mean the sex ratio varies with diseases. For example, with the IGLON5, there is a predominance, the last one, a predominance of men. With some other types of limbic encephalitis, like the second one, LGI1, it's a predominance of men. 65% are men. In the Nmda receptor, it's 80% women. And what is fascinating also is that if you pay attention to this, to this. Here is that after puberty, exactly, after puberty you see this a peak in more in women before, and if they are very young, the youngest is 2 months old. If you are very, very young, you see that this is more normalized, right?
So maybe it's independent.
Yeah. So yes, there is probably a hormonal component to that, as in some other autoimmune diseases.
Yeah, so actually, in many autoimmune diseases, MS is a good example. There's always a prevalence towards women. Okay, one, wow. Second, wow. But okay, let's focus. So Nmda receptor is also expressed widely on astrocytes, and so are there many neurotransmitters and receptors. So you've been focusing on the neurons, but this communication of astrocytes modulating neurons, survival, glutathione uptake, and whatever, it's a very interesting connection between the two. But I haven't seen any reference to the astrocytes throughout the system, so that's something that that's kind of interesting to me.
we don't see effects, systemic effects of the NMDA. NMDA receptors are expressed also, I believe, in lymphocytes. And,
Yep.
But clinically, you don't see anything surfacing, anything there, nothing bubbling when you examine these patients in terms. What really you see is in the white matter. In this disease, it's very interesting. The MRI of the Nmda receptor encephalitis patients in about close to 70% is normal. The clinical MRI.
Yep.
Clinical MRI. So you follow the patients, they spend months in the hospital, develop some atrophy, not very much, or sometimes no atrophy. And that's great, right? But when you do special studies with MRI, DTI, etc., and special sequences, what you see is that there is some white matter changes that you don't see in the regular MRI studies, okay? So and there is a group in Germany who collaborate with Finke, in that they have shown that the mean white matter diffusivity in the cortex of patients is also affected, but all of them with a special MRI study. So what we did is we look at the oligodendrocytes. Oligodendrocytes express very nicely Nmda receptor and Nmda receptors. So what you see is that if you treat oligodendrocytes the same as neurons, there is a reduce of Nmda receptor agonist responses in these oligodendrocytes, okay, compared with the controls. No, so the antibodies, of course, also affect the Nmda receptors in oligodendrocytes. So what's the meaning of that? Well, the Nmda receptors in oligodendrocytes are very important for when you activate the Nmda receptors. The oligodendrocytes export to the surface the glutamate, the glucose transporter 1 to the surface. And the glucose transporter 1 is critical for the metabolic support.
It's the same thing with astrocytes.
Of the axon, yes. So we look this in the oligodendrocytes, which is affected. And this could explain, I always like to make connections with the clinic, probably explain the transient effects on the white matter.
Yeah, the same mechanism will be in astrocytes.
We have not looked at the astrocytes yet.
Super interesting. What about the OPCs?
Not look at.
And can you see any migrations of OPCs or any inflammatory response? Well, if you do the PET for the activation of microglial astrocytes, will you see any difference?
Yeah, this is a step that we're doing now with a model of active immunization of mice. And the model.
What would you immunize with?
We immunize them with a
peptide towards
the peptide that contains the epitope region. Now, this is a conformational epitope, which complicates things. But we use a peptide of 29 amino acids, and the data is a very advanced model. I am presented for brevity. It has not been published yet, but it's very exciting.
And can you get a B-cell response?
Yes. So what we see in these animals are immunized on day 0 and day 28. And then what you see, these animals that they developed a very strong, we use an adjuvant that primes the B cells. The Freud adjuvant was not good for that. We use what's called Adapax. And they developed a very strong immune response with intrathecal synthesis and systemic synthesis of antibodies. And you see plasma cells in the brain, and you see that the animals develop the same alterations of behavior, even more. These are animals that, on top of all these behaviors of psychotic-like behavior, memory problems, anhedonia, they develop these interesting movements also, similar. So the animals walking, suddenly stop and start walking behind. So we have a model that I'm interested to study the acute phase of the disease, which in the patients we know how to handle, but the post-acute stage, that we have no idea how to treat these patients when they go home. You give more immune therapy, you only support them psychiatrically, you do cognitive rehabilitation, we have no idea. So we are doing that.
So that's really interesting because, well, two things. If you try to immunize mice with MOG3555, you get the EAE response, but it will not be a B-cell dependent response. To do that, we have to immunize with the full peptide, or at least 135 amino acids. This is Scott's work.
Yes.
Although recently there was this few publication about a BMOG that was supposed to do that. So that's really, really interesting. And what you're saying about the progressive is also kind of similar to what we're seeing in the progressive model of EAE, when it's kind of being a component that's happening within the CNS without the involvement of the peripheral immune system that much. It's kind of an ongoing system that is driving itself. So that's really, really interesting.
Yeah, so it took, this model has taken more than 2 years. It took many months just only preparing that with the float adjuvant and that, and then with the other vax. The other vax was the best. And no, I was telling all of this because, of course, you need this model to answer some of your questions, because the passive transfer is critical, is very important, because it demonstrates that the antibodies of patients cause all these things. But if you transfer the antibodies, the IgG, there is no inflammation in the brain of these animals. In the model that I show you, there is no inflammation. You transfer only IgG, no inflammation. You beautifully see all the antibodies do, but without inflammation. So now with the active immunization, you can look everything. You can look whatever cells come from the periphery, other contributors, and this is what we are doing now.
That's brilliant. 2 more questions. Is the passive immunization also, is the passive transfer also work in mice or only in rats?
No, we have not used rats.
I thought you said rats.
I show you, what I show you with sections of brain in terms of testing the patients for antibodies, we use rats. But this is for tissue immunohistochemistry. All the model is done, all the model is done with mice, and then some of the effects of the antibodies are also looked in mice, the tissue of mice, right? Yeah.
And why do you think the treatment works with this type of syndromes, and with NMO, for example, there's really nothing that works? The B-cell therapy does very little.
This is a fascinating finding also, and there is no quite explanation. You know, in the aquaporin 4, this is a complement-mediated disease, basically, right? In here, in the brain of this is IgG1, okay? So you could argue, well, there will be complement. There is no complement. In the brain of these patients, the is not complement mediated. You don't find deposits of complement. Because perhaps the reason, and this is speculation, is that the blood-brain barrier is very well preserved in these patients. Even when they have immune response, it's quite well preserved in these patients. And so the complement probably doesn't have a major role in this situation. The other thing is that in patients with herpes encephalitis that develop these autoimmune responses, the paradigm is different. These patients don't respond well to treatment. These patients are very affected. The children is a disaster to the outcome. And of course, these patients, the blood-brain barrier is totally affected by the viral infection.
That's brilliant. I love it. All right.
Is there any question? There are not online. One last question. We are amazingly late, but I think it's worthy. No, go ahead. No, I will not. Go ahead. No, go ahead.
Tomorrow we're enjoying
That's
it.
why I'm not stopping.
Can you elaborate about your finding and also your vision regarding the allosteric modulator? So it preserves the function of the receptor but prevents the antibody from binding it? What's going on there?
Yeah, this is a part of the brain paper that has to do with this publication when we publish that. There is a company that provides us the drug, and they were collaborators with this study that's called SAGE, and the name of the drug is SGE301. The allosteric modulation, which is a new part of treatments now, not for this disease, but for other things. The mechanisms are complicated, are complex to understand. They don't even understand clearly how this works, because these are derivative of cholesterol. They are integrated in the membrane and modify several things, modify even the trafficking of the receptors and so on. So the mechanism was not clear. So so we explored. So what happens with this type of modulation of receptors? So what happens is that what we found is that interfere but not completely block the internalization of receptors. So we looked this very nicely in vivo and looking and playing with different types of permeabilization of the membrane approaches. So to make the story short, when you have this potent allosteric modulator, the antibodies are still internal because they don't block directly the antibodies, or the antibodies are able to internalize receptor, but at less degree. And also seems to be that putting a break to this, there is in addition a more reinsertion of receptors. So it plays in both sides, but it's not very well understood that with the allosteric modulations. But now there are allosteric modulators for the AMPA receptors, for the Nmda receptors, and they are very potent. If you, for example, the reason that we use that is that if you, for example, use models of Nmda receptor non-competitive antagonist like ketamine or like what's the other one? It's okay. What ketamine? What you see is that these allosteric modulators also block the effects in animal models. So is a way like to treat this. So so this is why we approach that. But the mechanism is a little bit obscure.
Okay, thank you. Thank you, Leo and Joseph. So, Elias, I would suggest we have a short coffee break. And since it's cozy, we can move to a room on the other side. Yeah. And we convene back here at 12 for the final conclusions and also with the meeting with the representative from Friends of Tau. Okay. Thank you.
With so much more than what we came here. We got to know an amazing institution. The tour was amazing. Thank you. I thought that maybe when you put this in the program, you don't think what is going to be the impact of these little additions, but they were amazing. And we have a lot of common. I mean, the CAR-T, I think, was one of the things that we found yesterday. Engineering lymphocytes, I want to be, included. And we were already discussing some things, and we have common interests. We also see that neurodegenerative diseases, autoimmunity, immune, access is another thing that we are taking with us. And I'm sure your institution, and I'm not gonna leave a single cell analysis and epigenomics and transcriptomics outside. That's something else that we have, the bioinformatics, AI. That's something that is coming very, strong in cancer too. And it's something that we have to think maybe for the next meeting that we probably going to host in Tel Aviv, hopefully. And so thank you very much for hosting us. The hospitality was amazing. And I'm sure something was going to come from this meeting. And other than words, I also want to give a small presents that we came here to thank you. Elias, on representation here from the institution, the foundation. Josep, thank you very much. And José María, que está acá también. José María Nicolás en representación. Here.
Thank you very much.
And I'm giving this to Frederic too, that you can maybe, we were expecting to see at least Esther, but thank you very much, Esther. We couldn't have it here for you. So, thank you very much.
Thank you, Dinora. Now we feel very embarrassed.
No, you host.
Because
no.
Don't worry.
we see that still we need to learn hospitality. No, I think this meeting is probably reflecting why many of us are in the field of science, because we feel a genuine and naivety and genuine passion for knowledge. And no matter how far is the field from what you do every day, you feel attracted by what is new aspects and new generation of knowledge. And that's what I felt personally during this couple of days. And I think that's one of the things that is worth to highlight. And also, good science and good relationship brings ideas to continue, as we were asked by the foundations that brought us here, but also is what we are in science. We want to be practical. We want to go next steps, but we want to be realistic planning to this. And this couple of days, we discovered that we have many things in common, from resources that may be shared to enhance our research, our biobank, antibodies, expertise in certain areas. We have said in the meeting, expertise in how to bring basic science CAR T cells into the clinics, aspects that very few of us are interested. I don't see Julio now as regulatory aspects that are really important to develop. We learned the expertise that you have in Tel Aviv promoting transferring of knowledge into innovation, and it's something that we are really interested here and we want to promote. And so we saw these great possibilities to enrich ourselves from this collaboration. But also we want to be practical, and practical means we have to move in the same that we move from knowledge to innovation. We have to move from ideas to reality. And reality for us means to work in two lines. One is a future not very far away other meeting on the other side of the Mediterranean to increase our knowledge of each other and to continue sharing science in other way. But also we have identified at least two clear ways of cooperation. One is in the development of a CAR T cell against glioblastoma. You have the basic expertise. We have the possibility to translate it into the clinics. So it's a very clear collaboration. We also saw a project with immunoregulation in the neuro system. We saw some new aspects in immunology that could be bring together. So we would like to launch a call, practical call for put together projects in this area. And obviously it's very clear, no project, no money, no project, no money, no project, no collaboration. So we need to, and we ask for finding this seed money that has to be enough to that these projects are realistic. Otherwise, if it's little money, is a loss of them. So we prefer, and I will fully share the ideas of Giuseppe, is worth to put money that is realistic, worth to do a project. Otherwise, it's a loss for everybody. Loss of money and loss of time, and we don't want any of those. So I think those lines will be a little bit the conclusions of this interchange of ideas. And we are looking forward because certainly we saw from our science and from our interchange of relationship in just for these 2 days that this is interesting and realistic. So we would like to go in this pathway. And thank you very much for bringing us together, and looking forward for this to continue.
So thank you very much, Dinora. Thank you very much, Elias. I will be very, very, very short, and later Federica will close this remark or this conclusion or the next step. I really feel very, very happy when we start this meeting and this project. We really don't know how it will be, but as Elias mentioned, I think scientists are very easy to connect each other because the aim was exactly the same. So I think it was a fruitful meeting, as I heard from Elias and from Dinora. I think that's the first step of a very long collaboration. Yesterday we'll talk with Federica about how we could be the next meeting, and Josep Rodés from the coordinator of research in the hospital and an eminent cardiologist wants to do something on cardiology and on innovation on the next step in Tel Aviv, maybe next winter or next spring. So I'm sure we could do something together. And as Elias mentioned, there are different projects on immunology, on neurodegenerative diseases, and on CAR T cells, which could be collaboration. Now we know each other, which always is the first step. I am sure that from Tau University and also from Sterkoplovich Foundation could be some money and some help about that. Yesterday and on the dinner, I think could be good to develop projects, not only an agreement, because there is a MO, as Dr. Nicolas mentioned, from University of Barcelona and Tel Aviv University. So the MO is there. Now we know to go. Now we need to go one step further away, and we need to really concrete projects and go ahead on this way. So from my side, really thank you very much to be here. We're expecting to to come to Israel next time at the end of the year, or maybe on winter or next spring of 2023. And will be a pleasure to collaborate. I am sure will be different projects that we can do together. So thank you very much, and thank you very much to be here. Federica, I think it's your time to close, because I'm expecting a very small present from my office. It will take 30 seconds, but we'll be here in 30 seconds. So please go ahead. Take at least 60 seconds. Huh? That's important.
So, okay, I would like to thank you on behalf of the Friends of Tel Aviv University in Spain for having been part of this symposium. Thanks to Josep Maria Nicolas for the amazing organization. What has happened these last 2 days is part of the results of our mission. We are at your disposal to support you in what is necessary to start the different projects we took this morning and to go ahead. I'm going to read a few words from Patricia Nahmat, who is the president of the Friends of Tel Aviv University in Spain, because she is not able to connect via Zoom. So, in another tone. As president of Friends of Tel Aviv University Association, I would like to congratulate all the teams participating in this magnificent symposium. Hospital Clinic, University of Barcelona, IDIPAPS, Tel Aviv University, and especially the support received by the Sterkoplovich Foundation. Friends of Tel Aviv University in Spain has, among others, the function of building bridges between Tau and Spain, Spain and Tau. On this occasion, we are very pleased to have achieved it, wishing that this path started continues in future meetings, always seeking to make people's lives easier. Thank you all very much. I send you a big hug.
So thank you very much, Federica. Thank you very much, Dinora. And the presents are coming here. It's a very small thank you very much, Isabella. Thank you very much. It's a very small present. It's just a book from the hospital. I have some from you. It's a book from the hospital which explains a little bit the campus, university, this Sterkoplovich Center. It's a famous painter from the city who has a family in the hospital, and then during 1 month that the family was there, he drew all these painters. So I'm sure you will enjoy, and I'm sure for the members of the research, which also is important.
Thank you
very much. Thank you very much. That's good. There is somebody else? No? That's good. No, I give you one for your team.
Thank you, thank you.
So I think it's the end. Thank you very much to be here. I guess I have a good time in Barcelona, and have a nice trip back to Israel.
And we're
probably
looking forward
to see you, see us in Tel Aviv. Because yesterday I understand in Tel Aviv, no in Jerusalem.
No, Jerusalem.
In Tel Aviv.
You can go to Jerusalem.
But we cannot meet in Jerusalem.
You can visit if you want.
That's good. Thank you very much.